of insulin's use in pregnancy. So why is insulin used in the management of hyperglycemia in pregnancy? Because it is effective, it is safe, and it is easy to titrate in order to achieve the targets that we hope to when we are dealing with a woman who has hyperglycemia in pregnancy. For whom would we use it? Without a doubt, for women with type 1 diabetes, there is no other option, and insulin is the drug of choice in these women. In women with type 2 diabetes, in whom the oral hypoglycemic agent that they are controlled with is not metformin, it is ideal that we switch them to insulin, ideally pre-pregnancy, so that they are on a medication that is safe during pregnancy. But a large proportion of type 2 diabetics on metformin will require insulin going forward in order to meet the goals that we want them to keep during pregnancy. Now, what about gestational diabetes? True gestational diabetes, 85% of them will be managed with medical nutritional therapy, and when that is not able to meet the targets, then we would use insulin. So this is the stepwise approach to meeting targets, and when medical nutritional therapy and exercise fail, medication is a choice, and in the course of the course discussion, we will see how insulin comes to play there while we monitor and safely deliver this woman. So what are the targets that we need to achieve in pregnancy? Fasting should be less than 95, a 1-hour PP less than 140, and a 2-hour PP less than 120. Where have these numbers come? These are extrapolations from women with pre-existing diabetes. Actually, if you look at glycemic values in non-diabetic or women who don't have hyperglycemia, their means are much lower than these values, and that is something that we have to keep in mind when we are seeing a discrepancy between what is happening to the baby and what we are seeing as glucose values, and I will come to that when we go over the cases. What is then suboptimal control? If more than 30% of the values are out of range, then that is suboptimal control and we need to step up. How do we monitor the glycemic status? Intermittent testing in the lab is what majority of us do, driven by logistics, but it is not ideal. Home glucose monitoring to assess hypoglycemia and the variation and postprandial spikes, and today we have a lot of apps that help us achieve this, and especially in the type 1 diabetic, continuous glucose monitoring is helpful to achieve better control. Now, if you look at books, a lot of them will say 2/3 of insulin dose in the morning, 1/3 in the evening, and how you split it. But practically, we look at the glucose values and direct dosage. And if you have an elevated fasting, you cover it with a long-acting at night. And every postprandial spike you cover by using a rapid-acting for that meal. So today, human insulin is what is used, and human insulin is the least immunogenic. There are analogs such as Lispro and Aspart. Aspart are the shorter-acting analogs. They are comparable in immunogenicity to human regular insulin. They have acceptable safety profiles, minimally transferred across the placenta, no evidence of teratogenesis. The long-acting basal insulin analogs are also increasingly being used in pregnancy. They are usually given once a day. Occasionally, Detamir can be used on a twice daily dosage. So if you look at the short-acting insulin, typically the rapid-acting analog is short-acting. Onset of action is about 0.5 within half an hour. Maximum effect is 1.5 hours, decreases by 5.5 hours. The long-acting insulin starts by about 1.5 hours after injection. Maximum effect is 4 to 12 hours, and the effect can last up to 22 hours. So the newer acting analogs are glargine and Detamir. These are the two that are used in pregnancy. However, the data is limited. Yet, where does this safety data come from? The pre-existing diabetics on whom they are used continuously in pregnancy. Of the two, Detamir has more safety data, and you can use it twice daily if required. So this is the profile, and you can see the slight difference between the regular rapid-acting and the Lispro or Aspart, and the intermediate to long-acting NPH versus Detamir and glargine. And we need to understand that this peak is higher for NPH, but it is it lasts longer in the analogs, and this difference we have to keep in mind when the woman is on different types of insulin. What about continuous subcutaneous insulin infusion? Mostly the pump is used for a type 1 diabetic, and if a woman conceives on a with a pump, she can continue. We as obstetricians need to understand how it is used, and it is prudent to actually listen to the woman because she's lived with it much longer than we have interfaced with her. Obviously, this will require engaging and interacting continuously with the endocrinologist or the diabetologist, but we need to tell them that their requirement can increase. They may require 2 or 3 basal infusions, and per se, by using the pump, there is no clear improvement in maternal or fetal outcomes, and therefore, in a pure gestational diabetes, there isn't a place for the use of the pump. So we'll move on to some scenarios. This is a 28-year-old, BMI of 32, booking glucose sugars were normal. At 24 weeks, her GTT is this: 104, 222, and 213. Will we give her a trial of medical nutritional therapy? I think every woman with hyperglycemia deserves medical nutritional therapy. However, when the values on the GTT are over 200, it's unlikely that it will get controlled with that alone, and therefore we need medication. Why insulin and not metformin? Because metformin will take longer to bring the glucose under control, and we want her brought under control fairly quickly. And it is prudent maybe to ask her to do a SMBG for a couple of days to know what is happening in real time without the glucose load, and this is what happened. You can see that there's an elevated fasting on both days, and the post-breakfast is quite high. We have to sit and ask her what she ate, of course, and monitor that as well. So she will need a long-acting insulin at night, probably about 6 units to start off with, and then a post-breakfast short-acting. And then based on what is happening to the glucose, it can be titrated. And over the course of 10 days, this is how her glucose looked, with a long-acting at night and just one short-acting that covered breakfast, because her lunch and dinner were largely okay. And once we reach that, we can monitor and then make the finer adjustments. This is a second scenario: previous IUFDA 24 weeks, now GDM on diet, glucose being checked once in 2 weeks and apparently normal. But you see her at 32 weeks of a scan, and you can see that the abdominal circumference is hitting the 90th centile. So with these normal glucose values, why is this AC going higher? Probably because we don't know what is happening in between, and also probably because sometimes the baby can be sensitive to even what we consider normal glucose values below the threshold because of the way these thresholds have been decided. So this was the landmark paper by Kajos, which said we need to look at how the baby is growing to also monitor the glycemic control. So we looked at her, and the glucose values, her diet was off. After a week, her glucose values were between 92 and 102 fasting, and her PP was also consistently high. So definitely she needs to be started on insulin. She was started on 4 units long-acting at night, which covered both her fasting and her post-breakfast spike. But the question is that what we have to remember is starting at that point doesn't actually help to bring the AC back down, because the adiposity is already deposited, and so it's not a surprise to see polyhydramnios at 36 weeks and the baby still being high, but we need to keep the monitoring and adjust the glucose values. This is a third scenario. This was a type 2 diabetic who booked at 8 weeks. She was on metformin. You can see that the fastings are between 110 and 118, and all her post meals are high. So here we don't have the time to increase metformin to 1 gram twice a day and then see whether the glucose is getting under control, because this is a period of organogenesis and we want quick glycemic control, and therefore insulin is required. Again, this lady was started on Levemir 6 units, and then gradually by almost daily glucose monitoring, which was then sent by WhatsApp to the physician. And you must have that mechanism of daily monitoring if you're dealing with these kind of patients. If that's not possible, we may need to admit them. But if we are admitting them, we need to ensure that they're physically active and getting the right diet, and a rapid-acting insulin to cover her lunch and her dinner because, breakfast and dinner, because her lunch values most of the time initially were okay. And where there are spikes, if you ask them to note what they have eaten, you can then decide whether that's appropriate. Ultimately, on 10 units of Levemir and 18, 6 and 8 of Novorapid, this was the kind of control that was achieved, but it took about a month to get to the ideal number. The fourth scenario is a type 2 DM on metformin, good control, fastings between under 95 pp, 1 hour, definitely under 130, but the mother's not gaining weight. And if you look at the baby, it's hugging the 5th centile right from the start, and we do know that metformin is associated with increased incidence of SGA and low birth weight, and therefore you have to look somebody who's calorie restricting a lot and on metformin because of the fear of insulin. We need to sit and talk to them, and this may be a woman who you may switch despite the fact that her control is good, because she will benefit, the baby and she may benefit with insulin, so that you're not having a very low birth weight baby. The last is a 21-year-old primip who was a type 1 diabetic. She was taking her long-acting twice a day and short-acting 3 times a day. She went away after the 20th week scan here, came back at 33 weeks, and most of her glucose values were high, and you can see that the abdominal circumference is also hitting on the 95th centile. So this was a lady who, after she came back, was put on a continuous glucose monitoring, and today you have the advantage that you can read on a regular basis. You don't need to wait for the full 2 weeks to finish, which is too long in pregnancy, because you need to know what is happening real time, and with some SMBGs in between. And I'm just putting this chart so that you can see what happens. This is your time in range, and the recommendation is that 70% of the time your glucose value should be in range in pregnancy. Your hypos should be less than 4%, and the hyper should be less than 25%. That is what is considered ideal. Here for this lady, you can see that majority of the time she is high. Maybe 25-30% of the time she's normal, but thankfully there are no hypos, which is something that you need to watch out for in your type 1 diabetics. So this lady was titrated. We had to rapidly increase the amount of insulin, even though it was later on in pregnancy at 33 weeks. That is when she accessed our care, and then finally at 39 weeks she was induced and actually had a vaginal delivery. Intra partum, what happens? Insulin requirements usually decrease during labor because labor requires energy. There is muscle activation. We are also restricting calorie intake, and our main objectives are to maintain normal glycemic control, adequate calories, and adequate hydration. So we can do this mostly with subcutaneous insulin, and until recently there was no guidance on how to use this subcu insulin. Most of it in literature was about IV insulin. So, and again, there are no consensus in guidelines on the glycemic targets, but you like to keep it around 100 to 110, and if you consistently have more than 125, then you do IV infusion. This is from a recent publication which tells us how we can administer subcu insulin to cover the glucose values if you're doing SMBG. If the woman is on the pump, we can continue the pump at a lower temporal basal rate. We need to inform the nurses and the midwives that the woman has a pump, so they are not moving it around when they're strapping the CTG monitor, or it's not displaced. And after the placental expulsion, we have to reduce the basal rate on the pump. Some prefer to suspend the pump and switch to IV infusion. It depends on your comfort. Postpartum, majority won't need medication. We need to stop insulin on a true GDM. But if it's a pre-existing diabetic, then you revert to the pre-existing, pre-pregnancy doses. So it's important to keep a note of what that was somewhere. So in conclusion, we need to know who's the woman for whom insulin is required. And we need to watch not just the glucose values, but also how the baby is growing, because that combination will help us titrate the dose and achieve optimal outcome. Thank you so much for the opportunity and for also accommodating my request to go first. Thank you.